All right, good afternoon, everyone. Welcome to the best briefing of the day, our noon briefing today, where we'll address a difficult topic, but with bright prospects, I know. Getting at why some 6 million children die each year. The speakers on our briefing today are Rohina Joshi, Associate Professor of Medicine at the Georgia Institute for Global Health at the University of New South Wales, Dr. Robert Breiman, Director of Emory Global Health Institute, Executive Director of the Child Health and Mortality Prevention Surveillance, and also Abraham Flaxman, Institute for Health Metrics and Evaluation at the University of Washington. We'll get started. Thank you.
Thank you, Megan. Good afternoon, everyone. I'm going to begin with the problem statement that brings us all here today. So about 40 million children, so a third of all the children who are born, and 2/3 of all deaths go unrecorded. In addition to this, 2.6 million babies die before they turn 1 month old, and about half of these babies take their first and last breath on the day they are born, right? So the first day of their life. In addition to this, about 2.6 million children are stillborn. 1 million of these show signs of life at the beginning of labor. Now, majority of these deaths occur in low and middle income countries. About more than 100 low and middle income countries across the globe do not have good data on registration for births or deaths, and they do not have doctors to provide care or even certify a cause of death. Now, these are the countries who require this data because with the limited resources, they need to direct these resources appropriately, and hence, reliable, accurate data, which is timely, is extremely important. Now, we are not here to focus on the problem statement, but offer some solutions. And the solution that I want to talk today about is verbal autopsy. Now, this method called verbal autopsy is basically an autopsy by words. You ask a bunch of questions to the relative of the deceased and use that information to arrive at a cause of death. This method is not new. It's been around for 5 decades. But for the last 5 decades, it was research-oriented, it was paper-based, and also physician-dependent. Now, when we talk about some of these countries, the number of physicians per 1,000 population is less than 1 physician per 1,000. It's around 0.2 physicians per 1,000 population. So we're looking at methods that we can use without physicians, which are easy to use, which can provide accurate data and are timely. Now, just like the theme of the AAAS, about 10 years ago, we had computer scientists, mathematicians, specialists, doctors, and researchers who came together and formed the Population Health Metrics Research Consortium. Some of us here were involved in that particular study. And through those efforts of that consortium, what we did was validate the verbal autopsy questionnaire against deaths that occurred in hospital. What resulted out of that was something called SMART VA, and I will refer to SMART VA or SMART Verbal Autopsy often in the next minute or so. SMART VA is a technology-enabled tool which helps a lay but a trained personnel capture that information from the communities. They send it to a computer, and which gets analyzed, and what you get is causes of death, the probable cause of death, in real time. It is a blunt tool, but in areas where we have no information available, it is the best that we can get at this point of time. And it does provide a really good picture about the causes of death. Now, what we are doing with SMART VA is working around with different governments in different countries, around 12 countries around the world, to enable governments to understand what the cause of death is. Because of our work with the Department of Health in the Philippines, the Department of Health now knows what the causes of death for their children are. They know that pneumonia is the leading cause of death, followed by diarrhea, congenital malformations, and prematurity. Because of SMART VA, the government of Philippines can now plan and shape their health systems such that they can think about vaccine programs. They can find out which are the areas of their population who do not have access to care and therefore target those particular populations. This information is going to be useful not just for the Philippines, but other countries where this tool is now being used. So what I would like to end by saying is that smart verbal autopsy helps shed light in the area where there is no information available and where there are no physicians. Information from these deaths, with the help of smart VA, can help shape health systems and prevent child deaths in the future. I'd like to end here. Thank you for your time.
So I'm I'm Rob Breiman, and with the Emory Global Health Institute, Emory University in Atlanta. So the story that we're telling here is really not very complicated. You know, it's basically too many kids are dying. Rohina just described some of this, and there are huge inequities. So in many of the places we work in sub-Saharan Africa and in Asia, between 5 and 15% of children these days don't make it past their 5th birthday. And that, in contrast, is what we see in the United States, which is more like 1 in 166. Still not perfect. It's actually even better in places like Finland. But it gives you an idea of how much of a massive inequity there is. And consistent with that inequity, the United Nations, through its new Sustainable Development Goals, focused on 2030, made the ambitious objective known that all preventable under 5 mortality would be eliminated by 2030, and that 40% there would be a 40% reduction of childhood mortality by 2030. It's very ambitious because that sort of thing is not going to happen on its own. There has been a reduction in childhood mortality over the last few years, usually the last several decades actually, usually due to interventions that have occurred, more vaccines, better antibiotics, improvements in water and sanitation, some economic improvements. But in order to achieve those ambitious goals, there's going to need to be more clear and precise evidence than we currently have, so that these objectives can be reached with very clear and targeted interventions at the top priority diseases. I sort of think about it as if we were planning a moonshot, back in the 60s. Would we have gone ahead if we didn't have plans to understand how to get through the gravitational force, or how to keep people alive in space, and how to keep the spacecraft going towards its target? Where we are right now, we don't have enough precise information in order to get there. And so this brings us to the project that I'm involved with, which is called the Child Health and Mortality Prevention Surveillance Network. It's a result of sort of visionary input and support from the Bill and Melinda Gates Foundation. It's a long-term surveillance project that aims to get at what are the specific causes of death. We still will be doing verbal autopsy because that information is useful in collecting clinical data, but why is CHAMPS unique? What's unique about this is that we are collecting specimens from the bodies of children who have just died within 24 hours of death, a totally new concept in these areas. It hasn't been done before, largely because complete diagnostic autopsies are felt to be not feasible. They're very disruptive. They're disfiguring. They're costly. They take a lot of time. But we're at a nexus now where we have a new set of technologies where we can do these biopsies. We can do a collection of specimens through needles. And I didn't realize that was up, but let me see if I can. So needles like this is very much like what's done in living patients when there might be a suspected cancer or disease, where you go in and take a biopsy of an organ. And instead, this is done to collect specimens in strategic locations in all patients, and then subject those specimens to state-of-the-art testing. It's done locally as well on laboratory tests, but also histopathology that is done also locally, as well as at our central pathology lab, which is located at CDC. And with this, these specimens, we can do things that are really quite unique. And I'm going to give you one example. So there was one of our early cases, and we've had about 975 cases so far that have gone through this entire process. We're very early in the course of CHAMPS, but to give you an idea of what sort of information we can get. So there was, in this case, a stillbirth, 35-week-old stillbirth to a mother who was HIV infected, and it was a twin pregnancy. The twin survived and had a normal delivery, and the mother had had 4 antenatal clinic visits during pregnancy. So she's a good mom. She had gone even at 15 weeks of pregnancy to seek care. The cause of the stillbirth was felt to be clinically obstructed labor, and that was what was written down. That was the conclusion. Open and shut case. There was just a problem with labor, and it was called a preterm delivery due to this problem. So when we did our testing, we found our molecular testing revealed a pathogen called Treponema pallidum, and then we have antibodies to Treponema pallidum that are linked to a stain, so that we can then go into the organs and see if this pathogen is present. And what is most dramatic is in the liver specimen, and those red little curly specimens are spirochetes that represent syphilis. So this stillbirth was entirely due to stillbirth. It wasn't obstructed labor. It's a totally different conclusion. And importantly, even in a single case like this, there's data to action. So the family members were tested and treated, and importantly, syphilis testing is to occur during antenatal visits, and if a mother is positive for syphilis, she's supposed to be treated. But there were stockouts in the system, and the diagnostic tests were not available. So even when we have a single case, but when we have accumulated, aggregated cases, this is more powerful. We can go back into the system and say, look at what the consequence is of a stockout. And it's a shock to the system, it's a spotlight, and it can bring about change. We have a major challenge to get parents to agree to during their grieving period to allow this testing to occur. But we've used social behavioral science and community engagement and have had remarkable success and uptake among parents, because in many cases, the community leaders, religious leaders, parents get it, that by learning more about what's killing kids specifically, we can prevent the next group of children to die. And let me show you this interview with a community leader in Sierra Leone who was asked, why do children in Sierra Leone die? And this is a place where about 1 in 6 kids don't make it past the 5th birthday. So let's see if the video works.
That champs can let them come find out whose disease where they kill them pikia.
Well, if you had heard the whole video, she basically said that. It was only 10 seconds, Oh, that's strange. Yeah, so it got cut. But basically, she said that CHAMPS is going to find out what is killing children, and then that information will be used to prevent further deaths. During my presentation later today, I'll be giving more examples of how these data are useful as we aggregate them to consider changes in policy. And these data, in combination with the existing verbal autopsy data and death certificate data, are going to help, I think, to add more granularity to what we understand is responsible for childhood mortality. Thank you.
Hello, everyone. My name is Flaxman, or AB for short. I'm at the Institute for Health Metrics and Evaluation at the University of Washington. I'm really happy to be here today. I'm really excited to talk to you about this, some bit of a serious topic, but also in some ways inspiring topic. As Rob said, the kind of context that I'll give you to frame all of this is the Sustainable Development Goal 3, and particularly Target 3.2, which aims to end preventable deaths of newborns and children under the age of 5 by 2030. And when you talk about ending preventable deaths, we've really said we're going to quantify that by saying that we want in every country the child mortality rate to be at or below 25 deaths per 1,000 births, and the neonatal mortality rate to be at or below 12 deaths per 1,000 births. Now, a big project at the Institute for Health Metrics and Evaluation is called the Global Burden of Disease Study. And I really like the way Rob talked about a moonshot, especially because one of the things at AAAS today has been a 50th anniversary of landing on the moon. But imagine if we had been trying to do a moonshot without knowing the distance to the moon. And so a lot of the work that Rohina and a lot of the work that Rob are doing are bringing in the data that we need to measure these where we are. And it's not exactly distance, right, but a map of where we are in disease. A lot of the global burden of disease study is taking all of that available data and doing evidence synthesis to make our best estimates that combines all of this. And it's surprising to me, coming to this from mathematics, that we don't know where we are, but maybe it is surprising to you to find out that we don't know exactly where we are. Just knowing how we're doing is a challenge, and the global burden of disease is one of these pieces to putting together a answer to that challenge. So GBD provides a comprehensive picture of what disables and kills people across countries, time, age, and sex. And GBD estimates show that we're making progress globally towards our goal. So this chart now shows the global count of child deaths, which really are all estimates, but from 1990 to 2016 are estimates based on the data that's available. And then the GBD study has recently made projections going forwards to say, well, it's not 2016 anymore. Where do we think we are in 2019? And then remember, the SDG target is for 2030. Where do we think we'll be if things continue as they are to 2030? Now, I heard you might be interested in some numbers. So where we were in 1990, according to GBD estimates, is with 11 million child deaths per year, and where we project, forecast, but say that we think we are now is at 4.6 million deaths per year in 2019. And so this is a huge progress, and I think that while we say the SDGs are an ambitious goal, and getting to 25 deaths per 1,000 births is an ambitious goal, we also should celebrate that we've made huge progress. This is sort of the data behind a graph that Bill Gates tweeted 2 years ago, that he said, this is the most beautiful graph I have ever seen. And going forwards, we project that we will continue to make improvement, and that by 2030, there will be 3 million under 5 deaths. Now that's 3 million too many, and the way we've operationalized our Sustainable Development Goal 3.2, if we want every country to make it to 25 deaths per 1,000, we want that to be 1 million lower. So this, as Rob said, is an ambitious goal, but I believe that it is a possible goal. And really the reason that I want to bring this kind of story to the audience at the AAAS conference is because I think to make this goal, it's possible, but we need all hands on deck. So I want to bring this to the scientists in the audience, to the journalists in the audience, to say, we can do this. Now, one of the things that can help us to do this is going beyond this slide to the next slide in global burden of disease. And maybe if you pass me the cue, I can press it, or maybe it's possible to start breaking down these deaths into the composition of different causes. What I've shown on this slide is causes aggregated to relatively high level, showing the top 10 causes that we have projected for this year, 2019, and how that's going to change by 2030. And this assumes sort of things continue as they have been for the last 30 years, and it's aggregated to a relatively high level. So to break that down even further, neonatal disorders, Give me that, man. Neonatal disorders is really about the age at which the death occurred, and it would not be the number one cause if we tried to disaggregate it into the cause of those deaths in the earliest days. However, it's very hard to disaggregate what is happening in those earliest days, and one of the things that CHAMPS is probably going to provide really unique information on is what is happening in those earliest days. Diarrhea, LRI, and other is also a broad category, and to break down into our level 4 disaggregation, instead of what we've technically called the level 2 disaggregation I've shown you here, the number one cause in our level 4 disaggregation we call lower respiratory infection, or LRI. You can think of that mostly as pneumonia. But again, we don't know precisely what it is. And again, having this broad data from verbal autopsy as well as this deep data from minimally invasive tissue sampling is going to help us get more specific about that number one cause. The number 2 cause is a neonatal cause. It's a component of that number 1 cause on the list I've shown there, and it's preterm birth. And the number 3 cause is also a neonatal cause. We could call it neonatal encephalopathy as our internal jargon, or also sometimes called birth asphyxia. And number 4, right now, we have estimated is malaria. Now that's the one change in this ordering from 2019 to 2030. We have made huge progress fighting malaria in the last decades, and we can expect that progress to continue to some degree. We can expect it to continue to the point that the top disease shown in blue, which is the non-communicable disease category, is going to overtake that number 3, malaria and neglected tropical diseases. Now I'm going to give you one more slide and then wrap up, and that is to say, and perhaps you were already thinking this, these deaths are not distributed equally around the world. There is vast heterogeneity about what is happening where, and the Global Burden of Disease study can help us understand where this variation is happening. As you can see from what's shaded in here, countries that are shaded in blue are doing very well, relatively speaking, and countries that are shaded in red are the ones where there really is a lot more work to do when we're heading for our Sustainable Development Goal 3.2. I'll leave it there, and I really look forward to taking questions.
Thank you so much. So please raise your hand if you have a question. We'll bring a mic to you. Kindly state your name and affiliation before your question. Okay. So, Rohina, you had mentioned maybe you could talk about there are 12 countries, right, in which the Smart VA is already implemented. What are the next countries the next on the list where you really hope to see this being used?
Yeah, so the 12 countries where where VA is currently being used are mostly in the Asia Pacific, some countries in Africa, and a couple of countries in South America. So this was through a project called the Data for Health Initiative, which was funded by the Bloomberg Philanthropies as well as the Australian government. We are right now right at the end of that particular initiative, with the understanding that all the work that's been done over the last 4 years will be continued by the governments. And so all the initial investment and the training that's happened in the countries will continue on. We're looking forward to other partnerships and with the government, because the idea is that it has to be a project or an initiative which the countries themselves want to, they see that as important, and they take up that initiative to work along with us for it. So as of now, I'm not sure which the next countries are, but we'll definitely continue working within these 12 countries to support them and roll this out further.
Thank you. And I guess to follow up on that a little bit, here's a question. Yeah.
Yes, sorry, thanks. Roland Peace, BBC. You said quite rightly that 4.6 million children deaths is too many. But to get across the sense of health inequality, if the rates were reduced to what you have in the UK or America across the world, what would that number look like?
That is an excellent question, and I don't have it in front of me now. And I do have in the Global Burden of Disease estimates the evidence base from which I could compute it for you. So let's connect after this. I'd be happy to make someone work on that for you. What we could say is if everyone reaches that target, everyone who is above the 25 per thousand, then it would, by 2030, be 1 million a year lower. So instead of that 3 million deaths per year, it would come in at 2 million deaths per year.
And not to inject excessive controversy, but it's not really a given that that slope of that curve will continue in that way. And there have been a number of levers that have been pulled that have enabled the curve to take that current shape, but further reductions, it remains to be seen. And so that's assuming that you continue along that slope. If things flatten out,
you're quite welcome to inject that, because there's a quote that I come back to in this, that it is very hard to make predictions, especially about the future.
That was Yogi Berra, I think.
Okay, question here. Oh, Mike is coming.
I'm Alan Boyle from GeekWire, and I wanted to ask Abraham, is there anything in the metrics that suggest strategies for bringing down the numbers?
Thank you very much for that question. The metrics stop short of saying what we should do. So they go one step beyond the causes of death to known risk factors. An example would be, we know that exclusive breastfeeding is something that will prevent diarrheal disease. And so a lack of exclusive breastfeeding is a known risk factor. I'll give you slides in the talk later today about the specifics of this. We know that there are programs that can increase exclusive breastfeeding. Those are not currently in the global burden of disease. So the work that I'm doing now is to take one step beyond global burden of disease estimates, from saying here's where we are to saying what if this or what if that, where might we be?
So obviously the picture of childhood mortality in the US is quite good, but I think you mentioned, Dr. Breiman, that in Finland it's even a little bit better. What are they doing over there to take such good care of their children?
Right. I mean, that's the question. Everything is better in Finland. The vaccine studies that have been done for respiratory diseases and diarrheal diseases always perform better in Finland. So there is something worth studying. But the rate, the childhood mortality rate in Scandinavia, in Finland especially, is 1 death per 1 per 500 children don't make it past their 5th birthday. Again, so that's 1/3 of what we see in the United States and probably in the UK. The general explanation, it has to do often, but it's not really, to my knowledge, to my understanding, well described, is health systems related, and how there are fewer unreached children in Scandinavia than there are in places like the U.S. and the U.K., and certainly in Africa and in Asia. But the specifics around health systems, I think, hasn't really been teased apart. Even for us, we feel that, when people ask me the same question, at cocktail parties, which are rare for me to go to, but I often get asked, don't we already know? Why are you doing this? Don't we already know why children are dying? And we say in general terms we do, but we don't often have the specifics. And even for health systems, I mean, some people who are knowledgeable will say, just improve access to health care, and that will make a difference. But the devil is really in those details, because how you improve how you improve the health care so that access makes a difference, how you focus training and skills and diagnostic tests and all, have to be considered. And we think, again, some of this will be evidence-driven, because even so far, so we've done about 500 or 550 of these cases like what I presented to you, have gone to a local panel that considers all the evidence and makes a decision. And they walk away from those panels saying, I've learned so much, we're going to do things differently as we go forward, just from a few cases. So I think the data will be useful for improving health systems also in these low resource areas, very different in many ways from Finland.
Rohina, could you talk a little bit about how do you train people to implement the smart verbal autopsies? What are the questions that they have to ask?
Sure. So what we do is we have the entire questionnaire on not an iPhone, but an Android device. And the questionnaire it takes about 15 to 20 minutes. I've done a number of these trainings, and the way we go about it is, first of all, explain what we are doing, what's the purpose of it, because we want people to be enthused and motivated to do what, collecting causes of death seems quite a depressing task to do. So we start with something like that and go through each question so that the intent of the question is maintained when they go out into the field and talk to the families. So that's one aspect of it. We also train IT personnel in countries so that if there is any problems with technology, with connectivity, with that particular device, that they can resolve it without waiting for someone from another country to come and resolve these issues. So the training is about 5 days in all. When physicians are involved in SmartWay, like the work that I'm doing in the Philippines, we take less time because we don't have to go through all the medical terminologies with them, but we do spend extra time teaching them how to certify a death. We would think that it's a straightforward thing to do, but it's extremely important to get the right information in the right box. So we spend these 3 days with the doctors going through the questionnaire and then how to certify a cause of death. And we always end up doing several case studies, starting from introducing yourself to the respondent through to certifying the cause of death in these training sessions.
Question over here. Oh, go ahead.
Hi, I'm Laura Lamberti from the Bill and Melinda Gates Foundation. And I just wanted to ask, so from global health research, we know that an extremely important driver of under 5 mortality is undernutrition. And that doesn't actually show up as one of the direct causes of death in the GBD estimates, but it is an important underlying cause of death. And I know that CHAMPS is doing a lot of work to sort of suss out what are those drivers that are not in the direct causal chain, but that are in the causal chain nonetheless. And so I'm wondering if Dr. Breiman can elaborate on what CHAMPS is going to teach us about the role of undernutrition and potential targets for intervening in that pathway.
Yeah, thanks for that question. Just backing up for a moment, you've also highlighted, I think, one of the essential problems with the way we've been looking at data that comes from verbal autopsies and also a bit from death certificates, but more verbal autopsies. And that is, in general, the conclusion is that there's one cause of death. And there might be a few conditions specified, but usually what's used for those pie charts that you see is one cause of death. And so if a panel sees that a child is severely malnourished and also had pneumonia, what will get recorded is the pneumonia and not often the malnutrition. And for that reason, malnutrition often gets underemphasized. So one of the things we're finding so far with CHAMPS is that we do measurements on the body. There's also data from before death, from the clinical data. There's also photographs that are taken. And the panel that reviews all of the information decides on what is the underlying condition, then what are the next steps in what we call the causal chain, and then the immediate cause of death. And we take the counterfactual approach, which is you now have a causal chain, which is much more realistic, if you think about it, than what we're used to. And it's very possible that intervening anywhere on that causal chain might prevent that mortality. And what we're finding so far is, again, it's early days, but we have enough numbers from 5 countries so far to say that malnutrition is pretty darn important. So we're seeing it very often as an underlying condition. It sometimes also comes in as somewhere in the causal chain. But when we look at malnutrition in the causal chain as the underlying versus no malnutrition, the other conditions are different. So the immediate cause of death is different appears to be different for malnourished kids than unmalnourished kids. And we're going to need much more numbers, which will happen over time, to get to more specifics, but that may give some ideas too about how to approach and prevent death in malnourished kids versus not. Ultimately, again, it's a spotlight so that if people understand that malnutrition is substantially contributing to mortality, there will be a greater effort to do something about that. And at least my view, and I'm not an expert in that area, but I think others feel as well, that if you can get the child through that malnutrition, whether it be overall gross malnutrition or micronutrient malnutrition, that gives the child a chance to survive other insults that might occur. And so I think, again, there will be this sort of spotlight effect.
Great. Question over here.
Hello, I'm Valeria Roman from Argentina. I would like to know in which countries have you been implementing this initiative? You mentioned South America.
Yes. So in thank you for that. In South America, we're working in Colombia, Peru, Ecuador, and as well as Brazil is using a form of a technology-assisted verbal autopsy as well. So those are the 4 countries so far that we're working in so far. But it's a slightly different model. All of these countries have doctors. So what they're using is smart VA to certify causes of death. So it's the next level of verbal autopsy where a physician can review that information and then certify a cause of death.
Have the physicians reviewing the information been surprised about some of what they're learning?
Well, I can tell you in the Philippines, it's been really interesting. When I wrote the protocol for Philippines, I thought physicians would never want a computer to tell them what the cause of death is. But I've been pleasantly surprised. They've really liked the idea of being trained in a standardized tool rather than, asking questions just that whatever comes to their mind at that time, especially when they have absolutely no information. At the end of the training, we always receive really positive feedback about the utility of that information. Being trained in medicine, we try to prevent deaths. We don't focus much on deaths. So going through that training and understanding the importance of the death certificate really shifts that focus and also helps understand, that this piece of paper can actually be used to prevent premature mortality.
All right. If there aren't any other questions, thank you very much to our speakers. That was very interesting, and we really appreciate your time. Thank you.
Thank you all very much.